right. Hello, welcome everybody. So we will get started. Thank you guys for joining us this Friday. I'm Kelsey. I'm the program manager with MapNet here in Boston. And today we're very happy to have Dr. Weissman de Mamani to be presenting on a culturally informed treatment for families for young people with schizophrenia. So before we get started, just want to give two general announcements. First, we're very excited to be finally able to start offering CE credits for this series. So I'll post the link in the chat. This has more information about what kind of credits are available and also how to register for them. There is a nominal fee of $5 for it, but hoping to be able to offer these more regularly for our future events in the series. And then my other announcement, we'll post this link at the end as well, but we really want to start getting some feedback from these calls and also get some ideas of what kinds of topics folks would be interested in the future. So we will share that soon. But anyways, I'll pass it off to Dr. Friedman Yakubian to introduce our speaker today.
Thanks, Kelsey. Hi, everybody. It's my absolute pleasure to introduce Dr. Amy Weissman de Mamani. It's funny, I don't know the second half of your name as well, who is a professor at the University of Miami, a licensed clinical psychologist. Her research focuses on family and cultural factors that influence the course of serious mental illness. She has published 2 books and over 100 research articles related to mental illness. Her research has been funded by NIMH, the John Templeton Foundation, American Psychiatric or Psychological Association, and other agencies. In 2018, she received the Stanley Sue Award for distinguished contributions to diversity in clinical psychology by APA's Division 12. In 2021, she received the Trailblazer Award from ABCT's Psychosis and Schizophrenia Spectrum Special Interest Group. And probably one of her greatest distinctions, or one that is most exciting to me, is as Dr. Weissman de Mamani was my dissertation chair at the University of Massachusetts in Boston, and someone who really introduced me to the importance of culturally informed family therapy. And so I'm very excited for her to share her work with all of you. Thanks so much, Dr. Weissman.
Okay, well, thank you for that lovely introduction. And thanks, Michelle, for inviting me. I want to take a moment to say something about Michelle that now that you already know. She was from my very first cohort of graduate students when I started my career way at UMass Boston way back in the day. And I've been at the University of Miami for 25 years. So I'm sorry, Michelle, I know I'm dating you a little bit. I'm really dating myself. And so it's so meaningful to be here today with you now as a colleague. I'm very proud of you and I'm delighted to be here. So the title of my talk is The Development and Evaluation of a Family-Focused, Culturally Informed Therapy for People with Schizophrenia. Does everybody see the title slide fine? Okay. And so Michelle asked me to speak about my intervention and the treatment, the research that went into it, which culminated in in the publication of our treatment manual in 2021. So I'm going to talk about how we came to develop this, just to give you an overview. I'll start by talking about literature that informed the development of this treatment. Some of it was conducted in my lab, some of it by colleagues. And then I will talk about the intervention itself. I'll talk about how we tested the efficacy of the intervention, and the design, and I'll talk about our preliminary findings and where we're going from here. So most of you are in the field. I believe you're already aware of this, but schizophrenia is considered to be one of the most severe forms of mental illness, characterized by impairments in many different domains like thought processes, mood and functioning. And it affects about 1 in 100 people worldwide. And that's a relatively static statistic and fairly similar across countries, though we certainly see some blips and pockets. Interestingly, African Americans in the United States and in other countries where they are the minority in numbers have a much poorer course of illness. But that is only true in countries where they're the minority in numbers. For example, in some of the African nations where they're the majority, the prevalence rates is actually lower, slightly lower than our 1%. I'm fascinated by that finding, and I do some research in that area, but I'm not going to talk about that today. I'm going to talk more on the flip side. Another really interesting observation is that many people from minoritized groups in the United States or traditional groups in many different nations have actually shown a better prognosis, not a different prevalence rate, but a better course of illness once they're diagnosed. And I'll just say, when I say traditional cultures, referring to societies that tend to put group goals over individual goals, that tend to have clear hierarchies for how to behave, and things like that. And I became intrigued with this finding way back when I started graduate school. There was data in several waves of study from the World Health Organization where they used standardized assessment batteries, and they went to numerous countries around the world, and, using both the same set of researchers and local teams to help with the language nuances and things like that. And they found consistently that people with schizophrenia and related disorders who lived in the industrialized West, so the United States, Canada, England, had a poorer course of illness than their counterparts from countries like Colombia and South America, India, Mauritius. And I really spent the better part of my career trying to understand this finding and trying to see if we can capitalize on it and take some of the ingredients that these traditional cultures may be doing right and build them into intervention programs. So I'm going to start by talking about the link between the emotional climate and prognosis. Many of you probably are aware of the expressed emotion construct. It's one of the most widely researched areas in psychology and psychiatry. It's basically a measure of the amount of criticism, hostility, and something called emotional over-involvement, which is overly self-sacrificing behaviors or intrusiveness on the part of the family member to a person, to a family member with mental illness. And it's usually assessed during either an hour-and-a-half interview or a shorter 5-minute speech sample, which has good concordance with the hour-and-a-half interview. And the reason that this construct has received so much attention is that for people with the illness who are hospitalized, and most of these studies were done after the index hospitalization. That means the very first time they were hospitalized for schizophrenia or a related disorder. Those who returned home to live in high EE households were twice as likely to relapse within a 9-month period compared to their counterparts who returned to live in low EE households. And so one of the first studies that we examined in this series was to see if we might see some differences in cultural groups that might give us insights into the WHO finding of a better course of illness. And I want to say a couple of things. You will notice that my language changes when I talk about Latina, Hispanic, Latino clients through the slides, because it depends on the year. It depends on the city where most of the data was collected. So I'm not going to spend time talking about the historical reasons why my state uses Hispanic and the West Coast tends to use derivatives of Latina. I will say, so my slides will vary depending on when and where the data was collected. I'm actually using in most of my current research the phrasing Latine rather than Latinx, because Latine is a gender neutral version, and X is not a phoneme that occurs often in Spanish, and is already a way that adjectives can be gender neutral, like inteligente. So you'll see that is what I use for things going forward. But I just wanted to point out that there might be some confusion in that my language changes. But so back to the EE construct, a set of my graduate students who Michelle knows, they were my first, I saw her smiling. They were her lab mates in my lab back in the day. I took them on, some of them on a little road trip where we interviewed his Latina and Anglo-American family members of people with schizophrenia in Boston, Miami, and Los Angeles, using both of the gold standard measures of EE, so the Camberwell and the 5-minute speech sample. And we found that Anglo-Americans were indeed 3 to 5 times more likely to be rated as high in expressed emotion, depending on the instrument that we used. We also found in 2 earlier studies that attributions are linked to high EE attitudes. So high E relatives were more likely to see the illness and the individual symptoms as something the patients could and should control. And this was culture general. We saw that pattern in Anglos. We saw that pattern in Latinas alike. So that was general. And that kind of follows a basic social psychology model. So this was developed by Bernie Weiner with college students. So he said, basically, if somebody has an adversity or an event and we perceive that action as controllable, I'll give you an example. If you're, we're talking about college students, if you're in a calculus class and your classmate says, oh, hey, I don't have any notes this week for the test. Can you lend me your notes? If you attribute that person's adversity, not having the notes, and request to the fact that he was out partying all week and missed class, you're likely to feel frustration, anger, not a lot of sympathy, and a lack of a desire to comply and lend them the notes. Whereas if you take the same event and you attribute it to either the fact that he was sick or he had a death in the family that was largely out of his control, you're likely to feel warmth and sympathy and not a lot of anger and a resulting desire to help him. And so if we apply this same finding, our data suggests that when relatives perceive the illness or the management of the symptoms as something the patient can control, they're more likely to be critical, hostile, less warm, and less likely to want to help the participants. That's true for Anglos and Hispanics alike. But we wanted to understand whether this finding might also tell us whether the attributions that in this sample, I'm going to focus just in this for the rest of today, just on Latinas and Anglo-Americans. We wanted to see if the attributions that the groups make might give us insights into the World Health Organization's finding. And so for this study, and this is the only study that I'll talk about today that was analog, we wanted complete experimental control. So instead of assessing actual family members, we created vignettes of a person who we named Victor, because that's a name that works in either language. We described the person's symptoms and behaviors in detail in a way that met the DSM criteria. And then we had a set of measures looking at attributions and emotions and things like that. And we used translation, back translation. And we asked participants who were all psychology students at either the University of Southern California, which is a private institution in Southern California, and a comparable private institution called ITESO in Guadalajara, Mexico. And we asked them to imagine that this person, Victor, was their brother who was about a year older than them. And then they were asked to read the vignette, and then they were asked questions like, if you were in this situation with your brother, Victor, how much control do you think you perceive Victor to have over the illness as a whole, the management of the symptoms? How much frustration, anger, warmth, sympathy, things like that? And how likely would you be to want to help Victor manage his problem? And we found first main effects for Weiner's model, the more controllable attributions that all participants made, the more warmth, empathy, sympathy, and more desire to help. And the flip side, the lower, the more anger and frustration. But was really like interesting to us was that Anglos were significantly and substantially more likely than their Mexican counterparts to attribute the symptoms of the illness to factors within the person's personal control. And this is an opportunity to talk about culture right now. We don't think that Anglos are simply more critical people. And so you might be wondering, why is that? And it's really interesting. But if you think about the United States and some of the worldview of this great countries since our founding days, there is this notion that if you work hard, you can overcome and achieve anything. That's the essence of the American dream. And believe me, that philosophy can be extremely motivating, productive, and adaptive, but it can break down at times when it's applied to people who may not have complete control over their circumstances. And this isn't just a hunch that I have. If we look at measures of locus of control, for example, which is related to this, we do see national differences. In the United States, people are more likely to perceive that they and others have more control over their actions than countries like Mexico and other more traditional cultures. And if we look at related things like fatalism, which is kind of the flip side of that, in a way, things happen for a reason. We don't have, not that much control over them. We see much higher rates of that in Mexicans. Both styles have merits and downsides. So it's not Anglos are critical, but it gives us some insights into why they might have this view. They might have the same view of themselves. I should be able to do more. And so I just wanted to say that there are some reasons why we might see this pattern that link up to worldviews. So now I want to talk a little bit about religion and spirituality. I have been really interested and more interested in this construct over the years. First, it came sort of anecdotally back to driving around these cities and interviewing participants often in Spanish, but a lot of Latina participants. We kept noticing that there were references to God and religion in family members and people with the illness themselves in their coping with the illness. I have one quote here just to give you a flavor. In fact, in this particular study, we gave them the 5-minute speech sample, which is one of the measures of expressed emotion, where the entire prompt just says, tell me about so-and-so, your loved one with schizophrenia, and how the two of you get along. And we found that with this is a relatively unacculturated Spanish-speaking sample, we found that close to 40%, they were Hispanic, not all Spanish-speaking, but close to 50%, over 40%, made reference to God and spirituality in their coping with the illness, and that was unprompted. And we were struck by the fact that they were all using it in ways that seemed adaptive. because religion could be used in a really detrimental way. They could be saying, yeah, it's God's punishment for this illness, or they could be saying, well, only God knows what to do, so he'll handle it. We don't have to take him to therapy or do anything. But we didn't see that, and so I was intrigued by this was anecdotal. I was intrigued by the way our Latina clients were talking about religion. And in the 90s and early 2000s, all of this research was exploding that was showing, even like in public domain, like I remember on the cover of Time magazine, research showing that people who are religious tend to report, greater happiness, or less likely to divorce. They're reporting better health. One of my colleagues at the time, Michael McCullough, did a meta-analysis where they looked at all-cause mortality, so death for any reason, and found that religious people were less likely to die prematurely for any reason. And so, there's a lot of reasons this might be. It could be the social support. It could be that it tends to discourage detrimental behaviors like drinking in excess and smoking. And so it could be that. But it made us wonder a couple of things. One is people from traditional societies, especially Latinas, tend to be not only more religious, but they tend to integrate their religion much more in their day to day. So we wondered if that was one of the factors that accounted for a better course of illness. But we also wondered if for everyone, tapping into religious or existential, because I'm coming at this from a secular standpoint as a not particularly religious person myself, the ingredients that go along with religion, like having a meaning making system, having social support through church and or place of worship and related activities, soothing activities like prayer and meditation. And so we were interested in whether we might capitalize on that to help people who are so coping with serious mental illness. This paper is where we did a deep dive into the literature, just looking at evidence relating to coping with serious mental illness. And we found that a lot, the quality of the research wasn't as rigorous as I would like, but there was a lot of evidence simply looking at people's statements about how their faith, and it doesn't seem to matter what the faith is, help them manage dealing with a loved one with the illness, how much they benefited from their rabbi, their priest, their institutions, and even the people themselves. And for those of you who are in the field, you're probably wondering, oh, well, how do you deal with religious delusions and things? And I promise you, because that's a very important question, I will revisit that when I talk about the treatment. And so the last area that I want to talk about that fueled this, or informed, I should say, this intervention is family cohesion and collectivism. So one of our studies, and this isn't rocket science, we found that for family members and for people with lived experience with the illness, viewing your family as more cohesive, more supportive was associated for everybody with better well-being, less stress, less anxiety, less depression, and also lower symptom severity for people with the illness. And this is interesting because I think Anglo-Americans love their family members probably just as much as their Latina counterparts, but families tend to be more integrated. They tend to live in closer proximity. They tend to cross paths more regularly. So that also could be something that gives us insights into the better course of illness. So I just gave you a quick and dirty overview of some of the background that informed the development of this intervention. I'm going to talk now about the intervention itself. So the treatment has 5 distinct modules. 2 of them were completely developed by me, my research team, and 3 of them were borrowed and then modified to make them more culturally informed. So for family collectivism, the goal really is to try to fortify a strong sense of unity and to try to help the family to see themselves as a team that's working towards a mutual goal. And one of the ways we do this is we view the target of the intervention as the family itself, not any individual member. So we try to deflect blame away from any one person. And one of the ways that is you can almost guarantee right off the bat is to commend them for coming in the first place and pointing out that this is indicative of the fact that they have a commitment to one another, even if they don't see eye to eye on how to get there. They care about each other, and that you can almost guarantee when you ask them, what do you want to gain from this treatment? Almost everybody says, we want so-and-so, the person with the illness, to function better, and we want to get along better. And so then, we can point out that even if they don't see eye to eye on how to resolve their issues and their conflicts, they do have the same overarching goal. And so one of our main intentions from this module is to try to create a sense of interdependence, which kind of goes against, in some ways, the grain of of psychology, where we're trying to create independence, where the members feel like they are, extensions of one another rather than separate entities. And so in CITS, we have a handout that guides every single session and every module. And so we'll start by giving them a handout that asks them to explore what family means to them and what each person's role is in their families, to look at whether there's hierarchies that are working well or maybe not as well. And we ask them about what's their ideal family and what steps can we take to help you function more in line with your ideal family. And so we get into the nitty gritty of how each particular family functions and what they like about it and what isn't working. And for every session, the therapists are supposed to start by reviewing homework and then end by assigning homework. And so their homework might be to really reflect on how they might respond. They might engage differently and contribute differently. And to make sure that they're pointing out things that they really respect and like in other family members. And then we really emphasize commonalities and try to de-emphasize to some degree conflicts or differences in this module. And just to give you an example, we had a family of Cuban descent. It was a wife who had schizoaffective disorder, and she lived with both her husband and her mom, which is a pretty common occurrence in many Latina families. And she got along great with her husband and her mom, but she was caught in a crossfire between her husband and his mother-in-law, her mother, who were constantly fighting and bickering, and this was really stressing this client out. And of course, you can imagine when we got asked about what they were fighting about, most of their fights were about how best to care for this person that they both love so deeply. And so we were able to start by highlighting that they were actually more on the same page. They both wanted to help this person function at her highest potential, to keep her out of the hospital. Yet the way they were going about it was actually really stressing her out, which was making her more likely to relapse. And we were able to give a preview of what would come in the next module, where we would talk about expressed emotion and emotionally charged environments. And then we were able to talk to them about that we were going to teach them in later modules ways of communicating in a more respectful way. And interestingly, I would say right from the first session, where we pointed out, you're fighting about how to help this person. You both want the same things, and you're going about it from day one. They talk to each other in a much more low key way after that. And they didn't emerge best friends, but it was night and day, their relationship. It was the first time they were actually, especially in later modules, able to hear what the other was saying, because usually they were just talking past each other. They weren't listening long enough to even know what they were arguing about. So the second module, actually, we borrowed psychoeducation from Falloon and Goldstein and Miklowitz. I was a postdoc on their team, so I was doing this intervention with people with bipolar disorder way back in the day. And so the main goal of this, as it was originally designed, is just to educate about the known causes and exacerbating factors of schizophrenia and other related symptoms, and how the family and social interactions influence the client's moods and thoughts and behaviors, and is where we teach about EE and attributions, and help the clients get to know the symptoms. But we spend a lot of time talking about the family's own views of mental illness and how schizophrenia is perceived in their culture of origin, whether it's stigmatized, whether it's viewed as some gift, and we spend a lot of time talking about what the family views as effective routes of treatment, and not very effective routes of treatment. And a lot of times this is a place where clients will tell us about some of their concerns about mainstream interventions from their cultural background. And so we can talk about their practices, and whether some elements that they're doing might actually be totally indicated in CITS, if they have ways of worshiping, and then for things that might not be so healthful, like if they're, some of the First Nation and Native American tribes might be using peyote and other things that we know really isn't indicated if you have schizophrenia. We can talk about why and get at what is that practice, what need is it serving, and trying to find another related outlet, which I'll talk about with an example in a minute. But we spend a lot of time making sure they know what the symptoms are. We usually don't have to spend a lot of time on the positive symptoms, because people know what they're usually the ones that landed the person in the hospital, and they recognize those as symptoms. It's the negative symptoms, interestingly, that are often the ones that frustrate families the most, because they are things that we see in, even people without a psychiatric illness have on a continuum. And so, in fact, some of my team did some research looking at what are the triggers of high EE comments in different cultural groups. And it was fascinating. We found that our Anglo-American clients were much more likely to criticize symptoms and behaviors that reflected a lack of independence. So Johnny doesn't go to work, he's not finishing school, things that are not allowing him to launch. Whereas with both our Black and our Latina clients, they were much more likely to be triggered by violations of interdependence. So things like, he doesn't come out and sit with us when Aunt Susie comes over, or he doesn't smile, or he wears messy clothes at church. And so it's interesting that the targets of EE vary by culture. But one of the points that I wanted to make here is that educating about the negative symptom is often more productive, because those are symptoms that often are viewed as personality. And so that's how we get their attributions a little bit more realistic, in line with, it doesn't mean that people with the illness can't do anything about these things, quite the contrary, but helping them understand that to some degree they are symptoms of illness and not personality flaws. And having them really understand what the symptoms are and familiarizing them allows for an opportunity to do relapse drills. And so they know if they're seeing these symptoms ramp up, that it might be time to get a med consult, or to reduce expectations to a more realistic level. And then we talk a lot about genetics and how people get the disorder. In some ways, this can be helpful in, a lot of families worry, oh, was it that we did this thing or the way we acted? And, explaining that you can't, you need a biological predisposition to get the disorder. And so sometimes family members feel guilty about being the one to pass it on, but then we liken it, most people don't feel high levels of guilt about passing on a diabetes gene or something like that. And so we try to liken it to other um, medical disorders. And then because substance abuse comorbidity is so high, if we need to, if the person is using or the family members are using, we spend a lot of time talking about substance abuse, because if that's not treated first, cognitive behavioral interventions tend not to work very well. And often substance abuse patterns are maintained because of cultural rituals. That might be the bar culture in our white families. It might be I mentioned peyote rituals in Native Americans. And so we talk about it both as a cultural trait that might not be serving them, and as a behavior, not a trait, but also how it's particularly harmful for people with serious mental illness. And just to give you an example of this, we had a client who was pursuing a master's degree, and she was living with her long-term significant other. And one of their big hopes was that she would finish their program, that they would get married, buy a house, have a family. And one of their main wind downs at the end of the day was to sit on their balcony and smoke marijuana together. And so we were able to talk about their shared goal was to move forward economically and as a family. But marijuana use compromises everybody's cognition. And she was in a master's program, a rigorous program. So it was working against, that goal, but it's, we mentioned it's exponentially worse for somebody with psychosis. It's likely to trigger relapses, and so we got them to look at what need it was serving. It was their wind down and bonding time, and we got them to commit to, at least during the week, to coming home, putting on music that they liked from their background, salsa, making food together, and then having tea and sitting on the balcony and sharing their experiences of the day. Instead, they still smoked some, but it was limited to the weekends. And you could see as the sessions went on that the client's cognition cleared a bit. And so, of course, in this module, we talk about medication as the first line of defense. And so we support that. And we talk about balance, like clients should have people with the illness should have expectations. That's healthy, but keeping them balanced and in line with where they are functioning currently. So the spiritual coping module is aimed at helping clients tap into spiritual or existential beliefs about God and morality or the purpose of life, any spiritual supports they have or mentors, and practices like forgiveness, empathy. And we have two sets of handouts for those who are religious or are not religious that get at many of the same constructs. So we ask clients to bring in passages. They can be, from the Quran, the Bible, whatever speaks to them, or they could even, if they're not religious, they can bring in a poem or song lyrics. We try to have them match the passages to the module at hand. So if it's spirituality or if the issues that they're bringing in and struggling with, I'll say more about that later, about matching to the module, because it'll be more relevant later in this talk. And we use it as an opportunity to reframe any maladaptive uses of religion, where they might be saying that it's some kind of punishment, or again, using it in a way that we call spiritual bypass, like relying on the religion so that they don't have to take action. as I mentioned, we don't push anybody towards any religious stance. We have handouts that work just as well, that focus more on philosophical beliefs about right and wrong, one's meaning making systems, existential practices. It could be walks in nature, it could be yoga, it could be meditation, things that parallel. And you might wonder, well, what if, one family member is an atheist and another is religious? I actually spent a lot of time fretting over that as I was developing the intervention, but in practice, it really has been fine. People work from their own handouts. They set their own homework assignments. And family members often report really enjoying learning more about their loved ones' belief and backgrounds. And now the question that I promised you I would return to, you might be wondering, well, wait a minute, I thought it could be dangerous to engage in discussion of religious delusions, or to engage in religious discussions if somebody's having religious delusions. And I want to say a couple of things. One, CBT does not work well for clients who are currently more floridly psychotic. We operationalize that from the brief psychiatric rating scale, looking at the psychosis items of a 6 or a 7. So if with any delusions, if they're really psychotic, we send them out for the medication consult and have them come back when they're more stabilized. That research shows that in general, that because cognitive behavioral interventions, which this one is, requires a little bit of reality testing, we are only working with clients that they can have low-level delusions but are not very psychotic. And we have a rule that if a client is experiencing any religious delusions or hallucinations, the whole family goes on to the existential module, because we know that for any delusion, when you challenge it or when you engage it, the outcome is usually to reinforce it. So for that reason, no matter what delusion they were having, we wouldn't engage with them. We would distract, and so that is our rule. But because at our trial, we're not working with people who are having really serious levels of delusions. That generally hasn't been an issue. It would be an issue on a ward where you're trying to do this intervention with whoever walks through the door. And so just to give you an example of this module in practice, we had a client. He was a young man who was honorably discharged from the service. He was in his late 20s and he was living with his parents. And by this time, his positive symptoms were pretty much in check. He was mostly struggling with anhedonia, things like that, and the family was very, very Catholic. And the church activities, volunteer work was a big part of his upbringing. It was a big part of his social support. And so he was feeling cut off from others. He was feeling lonely. He was very embarrassed about where he was in life. And he hadn't gone to church because he was embarrassed. And so we were trying to use behavioral activation to get him to go back to church with his family member, which he was feeling incredibly guilty for not doing this, because it was a value that he not only enjoyed but really believed he should be doing. And so we got him to commit to going. He went. He came back the next week. He reported that it actually went pretty well, that people were nice to him, and very welcoming and happy to see him. And then we kind of upped the ante. So, okay, next time stay and actually stay after and mingle with people and go to some of the socials. And so we got him to do that. And then we extended it. He really wanted to meet people his age. We had him go to a Starbucks and to try to strike up a conversation. So we were able to use a value that was important to him as a behavioral activation to get him kind of out the door and doing things again. So now I'm going to talk about the last two modules. I'll talk about them quickly because they were developed by colleagues. We did modify them quite a bit to make them culturally tailored. But communication training teaches people, both the person with the illness and their loved ones, skills that are going to enable them to communicate in a more respectful, articulate, clear, concise way, so that they can advocate for their own needs better in a way that's less likely to alienate other people. So we teach them a set of skills that it includes sticking to the behavior at hand that they want to give feedback on, making sure they're using I statements and and talking about what they feel and not generalizing to the person, but rather on the behavior itself. And this skill is so important for all people, especially people who are close and couples and family members. We're often not listening when the other person is talking and we're formulating our own response. And we don't even hear what they say half of the time. And so this can be really destructive when communication and thought processing is already compromised. And so teaching them, fair, clear skills for communicating. And we spend a lot of time talking about styles of communication in their cultural background and maybe topics that are off limits for communication, where it's important for us to know, or sometimes it might be important if it might be something like finances, and because they don't talk about it at all because it's uncomfortable, but it's critical for the client's management or their well-being, or a couple, where sex is off the table. And so not always breaking down the barriers, but when we find we do the cost benefit where it's something that they need to talk about, helping them talk about it in a clear, concise, and in a manner that's less likely to trigger the other person. And it's also an opportunity to talk about how, and I'm going to spend more time on this in the next module, how we have limited resources to think about your beliefs and your values from your culture. Every interaction might not merit a communication. Like if your son is generally putting his dishes in the your son with schizophrenia is generally putting his dishes in the dishwasher, but forgets one day, maybe it's not necessary to raise it as a point, because to do the cost benefit and what really matters. And so same for problem solving. I'm going over this quickly, but we teach them a series of skills for how to operationalize the problem, because as I mentioned, people are often fighting about two different things and they don't realize it because they're not clearly describing what it is that they want to work on. We teach them skills to throw out multiple solutions before they prematurely evaluate them, and to think through the pros and cons for all of them, because there might be parts of them that are really valuable, and there also might be like recognizing why something is a bad solution can sometimes give insights in what would be a better solution. So we teach them a set of skills. Again, we send them out to practice and come back and either massage the approach to get it better, or if it's working, move on to the next problem. And here's where we also spend time helping them learn to pick their battles wisely. Like not everything merits their attention. And so, for example, if their loved one with schizophrenia, who they're trying desperately to get back to church or going back to family dinners and reunions and things, and the person's willing to go, but they want to wear their raggedy old jeans, like helping them decide what's really important in their cultural values, and like what's really important. Is it going to the events, or is it how the person is dressed? And so not everything needs to be always addressed, because we all have limited emotional reserves. So that was a quick and dirty overview of the intervention. It has 5 segments, as you know, and it occurs over 15 weeks. And we tested many things over the years, but the overarching hypotheses that we examined were that we hypothesized that families who receive this treatment are going to fare better, both in terms of their psychiatric symptoms and their general emotional well-being than those who received a psychoeducation control condition only. And if you look here, it says TAU, which stands for treatment as usual, but an astute reviewer pointed out that psychoeducation is actually way better than treatment as usual, because only about 4% of families get any family psychoeducations, and psychoeducation has been shown to be effective in reducing symptoms and improve mental health in family members. So it is much better than treatment as usual. But we randomly assigned the clients to either intervention group, and we assessed them on the same timelines. And we had a detailed battery of assessments. I'm not going to go through this. I'll just mention that we first confirmed that they did indeed meet criteria for schizophrenia using the SCID. And then we looked at symptom severity using the brief psychiatric rating scale. And then we looked at the family members' burden with the illness using the modified burden assessment scale. And then we also looked at other symptoms using the depression and anxiety stress inventory. And we looked at a range of other things that I'm not really going to talk about today. And we started by assessing our fidelity to the intervention. Were the therapists actually doing CITS and not doing things that they weren't supposed to be doing? We had independent raters look at the videotape, and we actually had really good fidelity, good adherence. So these Likert scales ratings are on a 7-point scale, with 7 being perfect adherence, or overall was a 6.17. Where we were the lowest was in homework. They're supposed to, according to the manual, begin every session with a revision of the last homework and assign homework. Sometimes they would forget one or the other, but we did this study early enough on that we were able to address that. And this was one of the reasons that it's helpful to assess fidelity. And we were happy that the interventionists were not doing things that they were not supposed to be doing, like directly challenging delusions or blaming the family for the symptoms. And not surprisingly, keeping a close watch on adherence is important. We did find that the more adherent the therapists were, the less likely clients were to drop out. And so, that it's important in keeping clients in therapy. And we also found high degrees of client satisfaction, again, using those 7-point Likert ratings. Our family members means were about a 6.26 for the people with the illness themselves, about a 5.75, which is not a particularly strong measure of efficacy. But if clients don't like the treatment, they tend not to stick around, and they also tend not to do the homework assignments and take the interventions and suggestions as seriously. And then for the main outcome, or one of the main outcomes that I'll talk about today, we compared progress on psychiatric symptoms after treatment, and we found that CITS outperformed psychoeducation in reducing patient psychiatric symptoms. This is controlling for their baseline level of psychiatric symptoms compared to treatment as usual, and that was a medium effect size. And then we did the same thing looking at burden. So lower scores are better because it means less psychiatric symptoms, less burden. And we controlled for baseline levels of caregiver burden. And we found that CITS outperformed psychoeducation with a large effect. And so we published those papers, and then we wanted to look at other outcomes and mechanisms of change. And so we looked at outcomes like reducing depression, anxiety, and stress. And we found, again, lo and behold, CITS outperformed treatment as usual in reducing those symptoms. And we also found that one of the main mediators was increasing family cohesion. So that was one of the things that accounted for the better performance. CITS did a better job increasing family cohesion than did education, which you might expect. And that was the driving force. Now, We also thought we would see increasing religion as a mediator, but interestingly, we didn't see changes in religion pre and post, which in 2020 hindsight, I'm not sure why we are expecting to. We weren't trying to make people more religious. We were just trying to get them to use their religion in a more regular day-to-day way. We did find the same pattern that everybody else is finding. We did find that that our people with lived experience who are more religious had less severe psychiatric symptoms. And we did find for caregivers using two different measures of religious beliefs and values and religious coping, that for the caregivers, being more religious was associated with a better quality of life. We didn't change their from pre to post. We weren't able to change. We should have measured it differently, but we weren't able to change their the strength of their religious faith. So to summarize, we found decreases in psychiatric symptom in patients. We found for both patients and family members, less depression, less burden, less anxiety. And we found that increasing family cohesion was one of the main mechanisms of change. I want to say a few more words about the religious piece, because we were left scratching our head, because CITS has a module that is, all about the faith, as you know. And so one of my doctoral students for her dissertation, looked at predictors of attrition. And she found that our religious clients were more likely to drop out of the treatment prematurely, and they attended fewer sessions. If we did survival analysis, and we found that almost all of our participants that dropped out did so in the first several sessions. Our spirituality module was in the middle. If they made it through the spirituality module, our attrition rates dropped to 0. And so this also made us wonder whether there might be a gap. Religious people might be getting their needs met elsewhere. And because we weren't talking about religion until the middle module, those folks who are going to drop out were already gone by then. So there might be a briefer window where you need to really address that this is a religious treatment, that it's going to capitalize on your beliefs and values. And it was too late. We wonder, it was too late by session 7. And so that was really intriguing to us. We applied for a Templeton grant, which was funded. And one of the main goals of that grant was to revise the next iteration of CITS to actually integrate spirituality from beginning to end, or existentialism, so that we open and close every session, not just the religiosity ones, with a prayer or a reading or a song or something meaningful to the clients. And we do it at every module. So I had mentioned this earlier, but it didn't fit as well there. So we tried to get them to bring in passages that reflected what the topic was. So if we were talking about communication training, passages or poems or things that spoke to them about that topic. If clients didn't bring them in, we brought the passages in ourselves to have a backup. And we also made other modifications. We wanted to, I don't know if you noticed this, but CITS, there's really only one module that's specific to schizophrenia. So we wanted to apply it to other disorders. So we developed modules for garden variety things, and we offered this version in group settings. So it could be for people, like we had one group for people with depression, anxiety, those kinds of symptoms. We had a group for people with serious mental illness. We included bipolar as well. And we included groups for Muslim Americans. We've been really intrigued by the fact and saddened by the fact that really since 9/11, but since 2016 and more recently, Muslim Americans are showing exceedingly high rates of depression, really high rates of suicide. and they are among the lowest consumers of psychotherapy. And so I was working with graduate students that both had a vested interest in Islam. And so we developed a culturally tailored version of CIT because it was the more general one for Muslims, and we pilot tested it, and then last year we published our treatment intervention manual, and so now we're looking at other populations. I'm very committed, and it's a tall order because talk about a population that does not seek psychotherapy. I'm committed to developing a CITP for police officers, a CIT version for police officers. Why? Well, police officers have, I would argue, one of the most challenging jobs that puts them at really high rates, high risk for psychological disturbance, and the data certainly bears this out. Police officers have 5 times the rate of PTSD, and twice the rate of major depression and attempted and completed suicide than their lay counterparts. And they also don't seek psychotherapy. And this is important to people in our field because some of our research shows that psychological distress in officers is associated with much greater stigma towards people with serious mental illness, and stigma is linked to both verbal and physical aggression. And also some of our more recent research shows that when officers experience high levels of distress, they're more likely to tolerate aggression towards people with serious mental illness in a colleague. So they're more likely to view the colleagues' aggression as reflecting competence. And so to us, this suggests that improving police officers' mental health might not only benefit officers themselves, which is a worthy goal, but it's also likely to impact the communities that they serve, particularly people with serious mental illness. So this is the main reason why I'm really committed to trying to see if we can develop an intervention that is culturally tailored. I've been, for the past couple of years, I've been doing in-depth focus groups with officers and asking them about what would it take to break down the barriers. So that was some qualitative research. Also asking them a sideline about what can we do to reduce the stigma towards people with serious mental illness. So the focus groups had 2 sets of purposes, but we're ready, I think, now to try to build this intervention. And the last thing I'll say about my current and future work that is really kind of thrilling for me, because in many ways this project brings me full circle. As you may recall from the beginning of my talk, I mentioned that my entire program of research was sparked by the World Health finding that people from more traditional cultures have a more benign course of illness. And about 7 or 8 months ago, my PhD mentor suggested that I put in a bid to become a consultant to the World Health Organization, because they're wanting to develop a treatment manual for psychosis for people from low and middle income families. And so I did, and there was some vetting, and I became a consultant for the last 6 months. And then I put in a bid to be a lead author on one of the manuals, and I was selected to write the Train the Trainer manual. So I'll be on both manuals. But that has been just a highlight of my career, again, because my whole program has been shaped by work that they're doing. And so this will be adapted, and eventually they'll pilot test it in middle and low income countries. So that's something that's obliquely related to my program of intervention research. And I have said enough, so I'm going to stop there, and happy to take any questions or comments that you might have.
Thank you so much. Yeah, a lot to, I think, dig into and think more about on our side. I would love to actually pull up Vera, your comment in the chat talking about when there is a kind of the misalignment in religion or culture between the, for example, like parents and a child is actually a source of conflict. And to turn that into a question, how has that shown up in this work, and how do you kind of approach that?
Yeah, that's a great question. I think I mentioned this. I thought that was going to be, one of our biggest challenges. It actually really was occasionally, but only a problem infrequently. And so one of the things that we set as a ground rule in the collectivism module is it's perfectly okay to disagree. We all have our own ideas, and in some ways that's healthy because we bring more to the table. It's interesting, but we have to be respectful. And so, in the religiosity module, if they were arguing about it, they could talk through it. We were like the mediators, and we would use some of the communication training techniques to say you can express your thoughts, but they can't. You can't. Target the person. You can target this behavior, like say it worries me that you spend so much time at church and not enough time at work, or whatever it may be, or your religion is weird, and or whatever it may be. They have to say it in a respectful way. They can't say you're lazy and you go to church because it's fun and your friends are there. They can say, I do have some concerns. I feel like perhaps you're spending too much time in your religion rather than working on your career or your schooling. And so we teach them ways to have those conversations. And that applies to every single thing that they're arguing about. As a rule, families tend to be more aligned on, even when you think about children, they're more likely their drug use and things like that is more likely to look like their peers, but their religion, their political affiliations often looks like their parents. So most families were more aligned, or one person really just wasn't that into it, and others were than being in very different religions. But we've seen it, and at times it was a source of conflict, like what the younger person might adopt a radically different faith, and that's annoying. And so we could even use it to talk through like what is so bothersome about it, and kind of get at values, and maybe if this is meaningful to so and so, let's discuss why that's important. And so treat it just like you would in any couples dynamic, or any other place where people are not seeing eye to eye or arguing.
Sure. And yeah, Vera, did you want to clarify or ask a follow-up?
Yeah, absolutely. I think that having younger people in the family diverging from their family's spiritual faith as being framed as being annoying to the larger family system is interesting to me. I'm wondering how much, in terms of, I'm not sure if you took these sort of demographic measures around like LGBTQ youth and how many people were participating in that intervention, and if there were any differences in how those people responded to the intervention, because that is something that's particularly common in Latin American families, is having LGBTQ youth in the family who have had significant experiences of trauma surrounding their family's religiosity.
Yeah, that's an excellent question. It's interesting because I'm doing a ton of work. Well, really, it's my graduate students, but I have two students doing masters and dissertations on that topic, not in CITS, but like wondering about whether faith is actually less protective in the LGBT community because of some of the dogma and things like that. Actually, and I would be willing to share this because we're about ready to submit this paper. For many people in the LGBT community, they often initially reject the faith, and many then come back to it on their own terms. Like a lot of congregations, Christian congregations, even one that I, through the Templeton grant, have collaborated with, are extremely welcoming to people. And so they're able to define God in their own eyes, in their own ways. And so that's kind of what we didn't have a ton of that wasn't like a common problem in our intervention, but that's one of the ways we would treat it, like talking about you don't have to agree with so-and-so's behavior or who they choose to love, but you have to respect them. And so we would treat it in the same way. But I do want to just say that we're looking at how religion can be a source of comfort to so many, yet for the LGBT community, it's often so blaming. And so we expected to see these patterns where religion, like being more religious, was associated with more suicidal ideation in this particular study, and we actually didn't see that pattern. And so I think the it's changing slowly, but I think the world is changing, where there's a greater acceptance, and many faiths are making a concerted effort. The congregational church that I go to often because I'm doing work there, the senior pastor starts with, I don't care where you are in your spiritual journey, I don't care if you're gay or straight, you are welcome here. And so I hope that is getting better. Like I said, that wasn't a regular issue for us, but we're looking at it, and not in a CITS context, but just more generally to different students. So if you reach out to me, I can share as we submit it, as long as you don't share it because it's not published yet, share a draft of the paper that I'm talking about.
I would suggest maybe potentially looking to see if there's any recruitment pressures, because given like LGBTQ trauma research and the numbers that we see there, that experience of people returning to the faith, it happens, but it's not like particularly common. And also with experiences of like things like conversion therapy, religious
Yeah.
abuse, those things are something that I think have a large effect in how people view their faith.
Yeah, and that is a huge concern. Like I said, in our intervention, probably just like in the population, probably 10% of the clients are LGBTQ plus. Maybe some are family members, maybe some of the person with the illness. It wasn't a regular issue, but yes, I can see we know for a fact that the church has done historically and religion has done a lot of damage to the LGBT community. And so again, somebody could come into this and decide, I only want to look at the existential exercises, I don't want to think about religion, and that would be absolutely encouraged. And and plenty of clients do that, so that wouldn't affect their participation in this intervention.
Awesome. Thank you.
Great question.
Michelle, I wonder if you want to follow up on what you put in the chat. So, thinking about this same topic of how kind of socioculturally things have evolved over time and how that's affected this intervention.
Thinking about you living in Florida and that probably being an interesting, the entire country is an interesting place right now, and Florida.
Yeah, I live in Miami-Dade, which is a little bit of a bubble. It's a little better, and I'm in the university. So, but it's a scary. I don't want to talk politics, but it's a scary state and and a scary time that we're living in. A minute ago, I said things are getting better. Talking like in the big picture, but they're certainly not feeling better right now. In many ways, we've taken 20 steps backward. The way that the climate has affected me is that I can't apply for NIH grants. It's just not, so it's affected me a little bit I haven't really changed my packaging. I just go for foundations, and I do research that's intervention focused. It doesn't have big needs. So it has, but I know we lost 22 grants in the university, and the grants that were hit were people who are doing LGBTQ plus work, working with Black and gay women with HIV. And so it's impacting this line of research for sure. I didn't lose any grants, but it's more I can't approach my research in the same way I could, several years ago.
Yeah, and a great comment in the chat from Natalia, talking about a Stanford study on differences in voice hearing in different cultures. So, wondering if you're familiar with this and how that in the U.S. voices are more intrusive and violent, and has that kind of informed
Yep,
your work?
I did a
Yeah.
study. It was published in 2000. So, oh my gosh, I'm so old. But it was looking at how culture influenced the manifestations of psychopathology. And you just said that study showed like what angrier voices, did you say? Because we found the exact same thing. We found more angry, critical, hostile voices in our Anglo clients. And then we found more somatic themes in our Hispanic clients. And that actually, the mind and the body are intricately connected, but we do see more somatization in our more traditional clients that where they, instead of a backache, instead of a head, anxiety, it's a backache and things like that. So we saw the same pattern, and it's not surprising if you think of dreaming, for example. When we dream, it's a form of psychosis, if you will. It breaks from reality, and we tend to dream about the things that we are currently experiencing. So if you're from a culture where your family members are critical and and it's loud, then that's the way your psychosis. You're likely to you can only distort reality based on what you know. People aren't going to I mean, sometimes they invent things. Sometimes that does happen in psychosis, but in general, it's a distortion of what you know. I'm doing a side program of research is looking at the manifestations of psychosis in English Spanish bilinguals. And we do, there's some evidence that people appear more psychotic in their mother or dominant tongue because, well, it could be because they have greater fluency and ability to express it, but it could also be that thing about like when you distort reality, you do it in your mother tongue. And so that was a long-winded way to say we found that same pattern in a study and published in Schizophrenia Bulletin in 2020, where culture manifests in the hallucinations and delusions that people have, which is not that surprising. We even our anxiety and even our like cognitive distortions for people who aren't impaired, they're an exaggeration of our own reality.
Great. Yeah. And the kind of follow up to that, which I think I really love how you worded this. Are there lessons from other cultures that could help reduce distress for people experiencing voices in the US?
Well, one of the things I mentioned, and this is great, in some cultures, a person with psychosis is revered, and so one of the things is because for some people, no matter how adherent they are to their medication, the voices stay, and so learning to be comfortable with the voices is also important. Like a lot of people navigate their illness better over time because they're like, oh, there they are again. Like they have some insights that they're not, that they are um, uh, hallucinations, and that they're not scared of them anymore. And so I think coming to terms with, okay, this is maybe part of me. And we do know some where it's backfires, some people who have voices and beliefs don't want to take the medication because those voices are their friends, and they might be the only friends they have. And so but there is something to be learned from that. If you're like when you're working with clients, if you have them anyway, learning to become more comfortable with them, and just learning to live with them, and that's often how people get more successful, even if the medication isn't completely eradicating the voices.
Great, thank you. I'll go back a little bit. So Ken had commented on the WHO project, talking about this being delivered by peers. And is that something that you would consider having peers in the country get trained in CIT as well?
I would love that. I think the reason that they're doing this is because most people or many people in these countries, especially the ones in the lowest economic rungs, which is this is geared towards, they don't they don't have the luxury of attending these established long-term interventions. And so the goal of these are to make them short, maybe 4 sessions, and to really packet all the information, because their experience, it's my first time ever working with the WHO, but their experience is that family members often drop out after a session or two because they can't get there, or they have other more pressing needs on Maslow's hierarchy of needs. And so I would love to do that. What I really want to do is go and deliver the intervention in Puerto Rico, because there's a high need. There's an aging population. They're not sufficiently equipped with practitioners that speak Spanish. And so that's something that we want to do. And the other thing I should say, that this group is probably the perfect target. We have not done a great job disseminating CITS. So I did talk to Miranda McLaughlin at MGH about the possibility of disseminating there. Anybody who wants to work with me on that, where maybe your team tests it and we apply for grants together and do it more multi-site, I would love to do that. So that could be in other countries or territories like Puerto Rico, but also we really haven't, almost all of the tests were our lab, and so we really want to have others use it and use it just to pick it up and offer it to communities, but also to collect some data and to continue to tweak it. So if any of you or people that might be interested in that, my email is on the slides.
And thank you, Michelle, for sharing the link to Salud. So this is our local community of Spanish-speaking clinicians in the early psychosis sphere, looking into culturally informed resources in Spanish. That's linked there. But that was a related question that I had thought of as you were speaking, which is how does it kind of affect the treatment when there's a different the family or client is speaking a different first language, use of interpreters, like I'm sure that complicates some of this.
I love that question. So what our rule of thumb was to try to use the language that was best understood collectively. And so that's what our manual stated initially. I was actually, because I was doing it usually I'm not the therapist, I'm the supervisor, and the grad students are the therapist, but I was the therapist because I was doing some training tapes. And I had a family, which is super typical. The mom really only spoke Spanish, and the kids were bilingual, but English dominant in some ways. And so at the end of the day, we ended up kind of relaxing it, where I spoke Spanish because everybody understood that, and the kids would often speak in English, and then I would try to paraphrase back, and the mom would speak in Spanish, just to allow people to express themselves in their most comfortable language. Unfortunately, we have to be realistic, especially if we're looking at other languages. We don't always have the luxury of providers that speak the language. So ideally, and this is part of the reason why it's so important to train a diverse class of graduate students, and why we want people of different races, with different linguistic skills, because we don't have enough providers that can, treat people in different languages, but that should be the goal. And if we can't have that, of course, an interpreter is the next best thing. What we don't want kids being the interpreters for their parents, especially in some of these traditional cultures, because it shifts the power dynamics. And if they're not professional interpreters, not intentionally necessarily, but they're offering modifying it to the way they see things. And so we have to do the best that we can do. And so if we don't have an interpreter, maybe that's better than no treatment. If the provider isn't bilingual in the two languages being expressed, using one of the members may be better than not having therapy at all. But ideally, we would have more providers who know the languages of the clients that they're treating, and we allow clients to express themselves in their more comfortable language. Because our research shows, I'm actually, I just submitted a talk to ABCT where we're finding that both people experience the valence of emotions more intensely in their, if in Spanish, if that's their native language. And so that's in psychotherapy, it's all about that. And so being able to express yourself in the language that you're, really feeling is going to be more productive, I think.
Right. So important. And I know something we've had a lot of conversations about here as well. Well, we have time for one more question. I also want to remind folks, Michelle, thank you for putting the link to the CEs in the chat. I've also put a link to our feedback survey, so please fill those out. But yeah, any other questions that folks want to bring up today? Right. And for folks who are interested in CEs, you will have to fill out a separate survey to do that. Yeah. Well, yeah, hearing nothing and seeing from the chat, thank you so much. This has really been an interesting discussion, and I'm sure a lot for us to learn from.
Great. My pleasure. Thank you so much for inviting me.
Thank you very much. It was wonderful hearing about your recent work and seeing you again. And we will definitely be in touch if you would like to share some materials with us and think about groups that might want to
Yeah.
try this out.
Yeah, absolutely. I'll reach out to you. Thank you. Terrific to see you.
Thanks. All right. Happy Friday, everyone.
Take care.